Hello, my name is Shaneka Hampton. I am a certified athletic trainer, and this is my final presentation for the Applied Research Project course at AT Steele University. I completed a quality improvement project looking to improve my medical documentation procedure in my setting as an independent contract athletic trainer and full-time high school teacher. To review what we're going to talk about during this presentation that you guys will hear today, and we're going to talk about the problem with medical documentation in this independent contract athletic training setting that I'm in. We'll also address the background of where medical documentation has problems within athletic training in general. We'll also touch base on the assessment for how the current documentation process is being implemented. This is before the quality project starts. We'll also talk about how the study is designed in the format of a plan, do, study, act cycle. We'll also address how the strategy was implemented in terms of carrying out the project. We'll also talk about the post-measurement results and what the outcomes of the improvement project were. We'll also address any lessons that were learned and limitations that hindered the project from advancing. And then finally, we'll talk about the conclusion of the project and how to advance this project any further for future testing. Medical documentation serves as a standard for allied health professionals to provide the foundational component in quality patient care. Governing entities of the profession, like the Board of Certification, when they mention in the role delineation study that documentation is one of the leading 5 constructs that compromise the roles of athletic training, it mentions that by law, every athletic trainer should be documenting every patient encounter that they have. Documentation can include, but is not limited to, patient demographics, subjective and objective information, and that can include clinical findings from the practitioner, the prognosis, and the clinical diagnosis that talk about the patient's health status. Lack of time and consistency and accessibility to secure methods are just some of the things that are most common obstacles of both full-time and independent contract athletic trainers alike. They all face some of the same problems during the documentation process. When addressing the specific problems within my independent contract setting, lack of consistency and knowledge of how to properly manage the process with high volumes of athlete traffic is one of the main things that I battle. Lack of funding is also a major factor contributing to diminished documentation adherence. Without the proper funds, the ability to purchase encrypted documentation software licenses and maintain secured privacy of patient encounters is hindered. This particular issue comes about frequently when documentation efforts are reduced to creating notes on my cell phone following high patient volumes and time restrictions. Subsequently, there is no standard checklist or process in place to monitor effective documentation. Now, patient care and documentation quality can be improved by focusing on the current process and ways to alter those practices to better suit the needs of me and my patients. Specifically, beginning a process that is simple yet immediate provides a standard for detailing the individual patient encounters that I have. So therefore, the purpose and the aim of this quality improvement project is to improve documentation practices by focusing on the specific setting. The ultimate goal is to have either greater than or equal to 80% of all of my patient encounters documented with quality completed checklists by the end of a 6-week time frame. Now, what you all see here is the fishbone diagram, which depicts my documentation process before the quality improvement project was actually implemented. Now, as highlighted in this figure, the independent contract athletic trainer, myself, was limited in the tools and equipment and environment and people surrounded by, and more importantly, the documentation process at hand. The initial current documentation practice demonstrated a need to improve by creating again a standard checklist to incite better documentation processes. Supplemental resources that were used were a personal computer, electronic media software, And that would also include the ATPBRN Core AT electronic medical record, iPhone notes, physical paper, and encrypted Google G Suite applications for the electronic patient encounter form that was created. To observe the methods of documentation processes as it stood before the implementation of the Quality Improvement Initiative that we just mentioned, a visual flowchart diagram was also created to depict said process. The current documentation process depicted begins by following any immediate injury away from the medical tent or consultation process, with the completion of a digital note on the cell phone, where the athletic trainer, following the initial encounter, documented immediate response care that was provided. The contents of the initial notes usually include patient demographics, which also mean the name, date of birth, the gender, the team name, sport affiliation, etc., and also the chief complaint of the patient. Basic subjective information is abbreviated with regard to the patient's body part that's involved or the injury or illness sustained. If the care is provided to a minor, the parent or legal guardian contact information is also recorded during this time frame. Now, due to the usual high volume of patient contact varying from basic first responder treatment to extensive evaluation and referrals, most of the patient encounter notes cease following the previously mentioned contents. So as you can see, the only time formal documentation practices are actually occurring are those instances immediately following the injury, whether it was on or off the field or court. Now, in most of these cases, no subsequent follow-up documentation or follow-up on the patient health status ever occurred. Now, as we mentioned before, the model for the Quality Improvement Project was used to, again, implement a checklist to refine the documentation patterns. A digital patient encounter form was also created to supplement the checklist in efforts to give more detailed encountered information. Anticipation of one plan, do, study, act cycle was expected to be completed during the 6-week initiative. Now, many quality improvement efforts of healthcare issues are driven by Plan, Do, Study, Act cycles, or PDSA cycles, to help organize, implement, and review any changes that are needed to ensure success in changing action. Now, for this specific project, the PDSA cycle was used to create the checklist and treatment log so that it can be quickly and easily used during athletic events and to be later input into the core ATEMR for safe, protected patient health information. Now, the actual physical action of the cycle will be implementing the use of the patient form and checklist via the athletic trainer, respectively. Simultaneously, while using the new documentation methods, we will carefully monitor the consistency and frequency of the checklist use, totaling all encounters documented and also totaling all encounters where both the athletic trainer and patient have fully completed the patient forms. All this data will be compiled in a spreadsheet for simple organization and the easing of the sorting process. Now, following the evaluation of the patient, a reflection and restructuring of the plan will actually ensue to accommodate further improvement efforts. Now, during this actual project, because we were not in the typical setting that we would usually be in for game coverage events, there was an injury clinic that was held 2 times a week in an established high school athletic training room under the permission of the head and assistant athletic trainer that are on staff there. Patient flow was steady and high volume and increased foot traffic occurred, but most of these patients entering the athletic training room had either previously been evaluated or were seeking pre/post practice game treatment using either like moist heat packs or ice, respectively. The goal is to evaluate between athletes who are seeking pre-practice taping or treatments, while others are being looked at for more thorough evaluations to establish the cause and treatment of painful or disabling dysfunctional movement patterns. The proposed way to incorporate the checklist and encounter forms to enhance the athletic trainer's documentation practices is to introduce all paperwork or digital documents by using the treatment at medical tent, or in the case of the specific setting used for this project, which was upon the initial evaluation during injury clinics at the high school. So you can see that instead of just having a note on a cell phone immediately after the injury or illness occurring on or off the field, you can see that the treatment log or checklist was inserted in those specific spots. So there's an easy transition into the current process, just making it more accessible for the athletic trainer to use. Now, as you all keep hearing me mention the checklists that were created, specifically checklists were chosen for this quality improvement initiative as a relatively easy process to incorporate into practice. Stasek et al. Proposed that more students and clinicians could benefit from using what's called goal-directed charting, or GDCs, in the instances where increased time is needed to produce a thorough record of continuous patient encounters. GDCs, or another method of checklist, help focus on the subjective and objective recounts of the patient and clinician while providing an organized framework that can be used to build upon more extensive documentation records at a later time. It has been shown to be beneficial in the early careers of athletic trainers, as well as other clinicians who may not feel as confident in completing their documentation in a timely manner. Employing the use of GDC recommendations of this study also correlates with those suggestions of another author, Nottingham et al., whose research proposed that simplifying the documentation processes with using strategies that are timely, consistent, and are driven by patient-rated outcomes are also beneficial with using checklists. An example of the digital or electronic patient encounter form is displayed here, where patients were able to express their own recount and perception of the encounter with myself. Again, all the information here was encrypted and secured for transfer to the electronic medical record that was mentioned at the beginning of this presentation. Okay, so during this quality improvement initiative, documentation improvement practices were conducted from January 17th, 2018 through March 2nd, 2018 for a total project implementation time of 6 weeks. At the conclusion of the 6-week mark, a total of 8 patients were either evaluated and or treated and documented on the treatment log checklist, as well as using the digital patient encounter form. Further, of the 8 patients, 2 of those patients, which were 25% of them, completed the digital patient encounter form separately. All 100% of patient records were actually partially documented by the athletic trainer, and we'll go over some of those definitions in just a moment. The first formal patient encounter occurred on January 24th, 2018. In the athletic training room injury evaluation clinic with a 15-year-old female high school swimmer/softball center fielder with bilateral shoulder pain. The athletic trainer and the patient were successfully able to complete the initial treatment log checklist and the encounter forms, respectively. The patient encounter demonstrated an example of a complete quality patient record and is defined by having the encounter recorded on the treatment log checklist and having the patient submit the encounter form with their responses. A partial patient record, or encounters described as partially documented, is defined as completion of the treatment log only. So that's that checklist there. Patient flow was steady. High volume and increased foot traffic was present, as we said before, but most of those patients entering the athletic training room had either previously been evaluated or were seeking some type of post-practice game treatment, usually, again, that moist heat or moist ice pack that we talked about. Now, while most of the improvement project was centered around physical and consistent quality documentation, you couldn't help but notice some other trends regarding specific information being recorded, like the age of the patient, of course, sport participation, injuries that were evaluated, and treatments that were provided, etc. So to note that we included that on table, 1.1, as well as table 1.2. The most common types of injuries that were evaluated were lower extremity injuries, and that was 5 of those. And those are also depicted in the same tables. And then we can also see other types of injuries that were evaluated. As I reflect on the implementation of this quality improvement study, I would like to begin by saying that having 25% of my documentation efforts be completely, fully documented through quality efforts was not ideal, but it was something to embark on by addressing that athletic trainers can find a way to implement a documentation process even in a crazy hectic setting like independent contract athletic trainers may have. Now, during this study, it was anticipated that I would improve documentation by implementing this checklist into practice. Now, not only is medical documentation again required by law, as we said before, but again, it has to be used to provide the best patient care possible. And detailing those revelations about the patient's current health or functional status, it just further protects the athletic trainer and the patient in any changes along the way with any of the treatments that were provided. Now, an additional outcome that was expected was the overall improvement of the quality of care given for the overall health related quality of life of the patients that I encountered. Now, although this setting again is generally experiencing one time patient encounters, even that expectations of the quality care were expected to improve, which did happen. Now, improving the patient encounter documentation by 80% of the 6 week time frame was the short term goal. It was realistically attainable, but again, unfortunately, not reached under the conditions that were available. In the long term, an additional goal would be to consistently have, of course, 100% compliance of this setting to help maintain the medical records for this practice. Now, no current documentation efforts or implementation of the new process occurred within that typical game event coverage scenario that I'm typically used to. Now, because again, the nature of the high school clinical evaluation setting, again, mass amounts of patients were seen, making it difficult to give thorough injury evaluations. Now, while this high school setting does kind of mimic the waves of athletes that would be experienced during typical sporting event game coverage settings, most of the encounters of athletes, again, were not in the correct manner because they were all filtered to the previous athletic trainers that were on staff. Okay. Also, subsequent to difficulties influenced by the environment of the setting and nature, most of the problems, again, came from the athletes themselves just filtering themselves to the athletic trainer on staff. So it made it just difficult to triage the patients. And it also made it difficult to develop that rapport to initiate a patient encounter to document. So hopefully in future efforts of this project, I would actually like to find a way to address other avenues of getting out this checklist in patient encounter form. Now, if I'm able to have, again, multiple avenues of this access to this digital form, whether I have another iPad or just another form of access, it can help increase the efficiency and efficacy of my documentation process. Now, because I'm limited to access to these multiple technological devices, getting a little tongue-tied there, excuse me, having access to maybe a simple URL code or a QR code, may allow for the patients to use their own devices to effectively fill out that patient encounter form. Also, maybe having something like business cards that have standard information regarding how to access that digital encounter form may be another simple solution. I also like to try to use more of a checks and balances type format when I follow up with my patients to see how they're doing. So maybe again initiating a reminder call or text to aid the patients in how to access the form, as well as just getting the document completed might be something that I need to do. If the only means to conduct another PDSA cycle rests on implementation under the same conditions, like hosting an injury evaluation clinic, the other athletic trainers on staff would have to be involved in a more integral way to share the same documentation processes that I use, and it's only during those times. That would definitely increase the consistency, the efforts, and the ability of maintaining records for every patient encounter, like we talked about before, that's needed by law. Also, to try to bridge that gap between the athlete's unfamiliarity of the independent contract athletic trainer, myself, during those clinic times, I'd like to again have the athletic trainers on staff or maybe myself provide some type of announcement, whether it be at athletic meetings or posting some type of signage, just to get that general word of mouth out about when injury clinic days are, so that can also increase patient encounters and increase more opportunity for documentation to occur. These increased opportunities for documenting encounters will lend better evidence to the successes and failures to evaluate and or reconfigure what's needed to reconsider and get the desired outcome. And just like we mentioned before, just trying to again establish that mode of communication so that athletes coming in would know who I am, so they're not taken aback and only going to the athletic trainers that are on staff. I could help diffuse their overflow of athletes by giving again those more thorough injury evaluations, and also again increasing my documentation efforts under high volume athlete traffic settings like I would experience in those game coverage or sporting event coverage type situations. Now, all in all, I have to say that documentation practices were improved throughout this project. However, limitations of time, the number of patients encountered, and the documentation delivery hindered the ability to document all the patient encounters. And again, this was definitely seen with, again, that high volume influx, the athletes filtering to the other athletic trainers that could have better been managed. So hopefully in the future, I can focus on, again, different delivery modes of that digital encounter form so that I can increase the likelihood of enhancing my documentation completion in my setting. Now, I actually thoroughly enjoyed this process of trying to implement a improvement effort that would make my practice better in my specific setting since it's so unique. So I have to give a special thank you to my advisor, Dr. Rochelle Williams. You were an integral part in this project in more ways than one, as I stated. I am really, really grateful for all of your support and oversight in this project during this time. It was a long road ahead, but I have finally made it through to the other side, so I am so appreciative of all of your efforts to help. Also, to everyone else that's affiliated with the A.T. Steele University Doctor of Athletic Training program, like I said before, this has been truly an amazing experience, and we will definitely continue to innovate and lead this profession to better serve our patients with the care that they deserve. I look forward to seeing all of the new projects and things that are unfolding from this group of doctors, and I can't wait to, again, implement my own research and projects to help further advance this field of athletic training. So thank you for enjoying this presentation, and we will be in touch very, very soon, people. Have a great rest of your day.